This is a comparison of the United States and Canadian healthcare systems. The United States and Canada share the longest border in the world, much of it along the 49th northern parallel in North America. The two countries are historically intertwined, supporting one another in trade and military endeavors consistently. One big difference, however, is their individual approaches to healthcare. Before 1971, both the US and Canada had very similar health insurance expenditures. Each country spent about 7.1% of their gross domestic product in healthcare. After this date, each country went their own way. Slide 2. Canada's version of healthcare started in the 1940s when several provinces started a compulsory health insurance program. Just after World War II, the province of Saskatchewan was plagued by inadequate health coverage for its citizens. The provincial government started a hospitalization plan to address the shortfall. Under the plan, a regional system of hospitals was created. It featured local hospitals for primary care, district hospitals for more complex cases, and base hospitals for the most difficult cases. In 1956, Canada's federal parliament built off Saskatchewan's work and passed into law the Hospital and Diagnostic Services Act. This act established the framework for a national system of hospital insurance. By 1961, all 10 provinces and 2 territories participated in this act, which had the federal government reimburse for half of the hospital costs. Later, in 1971, the National Health Insurance Plan added coverage for physician services in addition to the hospitalization coverage. The Canadian Health Act of 1984 defined how the healthcare system works today. It is built around a type of Medicare or government-run National Insurance Program, or NHI. The NHI covers 97% of citizens, and the remaining 3% are covered under the federal programs. Most hospitals are government-run institutions, and both public and private providers see patients. Slide 3. To every Canadian citizen, with a few minor exceptions, healthcare coverage is available to all with no co-payments or other out-of-pocket types of charges. Physicians are paid for a fee for the services they provide and have independence to treat and run their practices as they wish. Privately funded health insurance, like we have in the US, is illegal. Most Canadians purchase supplemental insurance to help cover services not covered by the NHI, such as dental care and prescription drug purchases. Another benefit of the Canadian healthcare system, especially when compared to the US, is that the patient is excluded from reimbursement process. Instead, the government and the providers work directly with each other to make sure services rendered are paid for. There is never any money due from the patient. Slide 4. To control costs, the Ministry of Health established fixed comprehensive budgets and uses a fee schedule with physicians. Additionally, the operating budgets of hospitals are approved and funded entirely by the ministry in each province, and an annual global budget is negotiated between the ministry and each individual hospital. Capital expenditures must also be approved by the ministry, which funds the bulk of the spending. The Ministry of Health also holds periodic negotiations with the Provincial Medical Association, equivalent to the American Medical Association in the US, to find an equitable schedule for fees to be charged to the government for physician services. One unique monetary change or strategy the Canadian Ministry of Health uses in tying volume increases to rate increases to curb unnecessary treatment. If a physician increases the volume of the services he provides faster than the target he was assigned by the ministry, his annual fee schedule increases would be reduced or eliminated. While this helps give the physician complete autonomy to see and treat whatever patient he likes, he must be careful not to render unnecessary services for fear of exceeding his volume quota. This helps the Ministry of Health keep expenditures low. Slide 5. Due to a poor economy, the Canadian government began cutting its federal health care budget in the 1990s, and these cuts have increased every decade since. 2013, Canada spent just 10.7% of its gross domestic product on health care. This has led to a host of problems for the healthcare system, including long waiting times and poor access to technology. Slide 6. On average, Canadians can wait 13.3 weeks to receive treatment, about 1/3 longer than physicians feel is clinically reasonable. This can be especially difficult for the elderly who have increased need for timely care. Also adding to wait times is the lack of technology available. In 2006, there were only 11.4 CT scanners per million of population in Canada. In the US, there were 32.2 scanners per million of population. One reason for the lack of technology in Canada could be the low rates charged for a scan. This limits the government's ability to provide capital dollars for additional scanners. If Canada continues to cut its government funding of healthcare, limited and timely access to healthcare for Canadian citizens will continue to be a problem. These cuts have led to hospital closings and mergers, which compound the problem of limited and timely access to healthcare. More federal money must be dedicated to reverse this trend. Slide 7. Traditionally, the more money you spend on something, the better it gets. Unfortunately, the exact opposite is true with the United States healthcare system. The U.S. spends substantially more on healthcare than Canada. Despite the high cost, the U.S. ranks last among wealthy countries when comparing care quality, access, equity, life expectancy, and infant mortality. According to the Commonwealth Fund, the U.S. spends 17.1% on GDP on healthcare costs. The next closest country, France, spends only 11.6% on healthcare. As discussed before, Canada spends only 10.7%. Much of this spending is driven by technology. For example, there were 107 MRI exams per 1,000 people in the U.S. in 2013. In contrast, only 53 MRI exams per 1,000 people were performed in Canada. Slide 8. One explanation for why so many imaging exams are performed in the U.S. is a concept known as defensive medicine. Defensive medicine is the overuse of tests and procedures for fear of malpractice litigation. It is estimated that $46 billion is spent annually on defensive medicine. In a study published by the Journal of American Medical Association, 4,215 orders were studied from 36 physicians across 3 hospitals. The study showed that 28% of the orders were determined to be at least partially defensive. Most of the orders were for either diagnostic testing or for longer hospitalizations. The study does not, however, link these defensive practices with an improvement in patient outcomes. Canada's physician quota on services provided eliminates this practice in their system. Slide 9. Technology use also creates a significant amount of cost to U.S. healthcare consumers due to its high acquisition and ongoing maintenance costs compared to Canada. A CT scan cost $896 on average in the U.S. The same scan only costs $97 in Canada. Insurance companies could develop strict guidelines for payment of these imaging procedures and other technological treatments, helping to regulate the huge cost swings across the marketplace. Slide 10. An additional driver of healthcare costs in the U.S. is the lack of a single nationwide system for health insurance. The U.S. uses a blended approach to provide healthcare coverage. T.R. Reid stated in the Washington Post that we use a combination of Britain's, Germany's, Canada's, and Burundi's healthcare system as our model. Veterans and Native Americans in the U.S. receive government-provided healthcare funded by federal taxes, the same way Great Britain's citizens receive their healthcare services. Many people in the U.S. receive health insurance through their employers, where they pay a portion of the insurance premium and the employer pays a portion of the premium. This is the same way citizens in Germany receive their healthcare coverage and is referred to as a dual-payer model. People over the age of 65 in the U.S. receive insurance from the federal government, called Medicaid. All citizens in the country pay for this government-run insurance. This is the same model Canada uses for its citizens. Unfortunately, many people in the U.S. don't fall into one of these categories and must pay cash for their medical care. This is the same method used in third world countries like Burundi. This blended approach of healthcare delivery leads to high insurance and administrative costs. Slide 11. In the U.S., administrative costs account for 25% of all hospital spending. In Canada, the costs are around 12%. In addition, private insurance is illegal in Canada, instead having healthcare provided directly from the government. Finding ways to eliminate profit from health insurance in the U.S. could move healthcare industry towards a more sustainable track without impacting the quality of care provided. Also, because of these high administrative costs, health insurance is becoming unaffordable for U.S. families. By 2033, projections by the Annals of Family Medicine show family health insurance premiums surpassing household incomes. Slide 12. Nonetheless, all this spending in the U.S. does not correlate into better quality of care. The median life expectancy at birth for an OECD countries is 81.2 years. The U.S. has the lowest life expectancy, however, at just 78.8 years. Canada just beats the average with an 81.5-year life expectancy. Smoking could be one of the major detriments of this lower life expectancy. Smoking in the U.S. reached a higher peak than other countries, with smoking among women being especially high. Ovando and Kawachi conclude an annual review of public health Due to the long lag between smoking and lung cancer, current mortality reflects smoking trends 2 or 3 decades earlier. A recent study concluded that smoking explained 2/5 of the difference in male life expectancy and over 3/4 of the difference in female life expectancy. Despite the current low rates of smoking in the U.S., it appears our previous sins are catching up with us. The U.S. also has high infant mortality rates of 6.1 deaths per 1,000 live birth, compared to Canada's 5.1 and the OECD average of just 3.5. It is unlikely parental smoking alone can account for this rate of infant mortality and poor childbirth outcomes. Scientists believe the biggest factor in infant mortality can be traced to premature births. However, the cause is difficult to determine. To some degree, high blood pressure, drinking, and diabetes are factors, but high levels of emotional stress and socioeconomic divides appear to be the most likely causes of premature birth. Kaiser Permanente has performed a study that shows that getting at-risk women care early in pregnancy resulted in fewer preterm births. They calculated extending this program across the U.S. could save the U.S. $2 billion in health care costs a year and would make a positive stride in lowering the infant mortality rate. Every little improvement helps. Overall, even one extra day spent in gestation increases a baby's survival odds by 3 or 4% per day. Studies have also shown that extending job-protected paid maternity leave to new mothers can improve infant mortality. Having a 10-week fully paid and protected maternity leave policy can result in a 2.5% reduction in overall mortality. Changing U.S. policy to incorporate conclusions, this data shows, could have a dramatic effect on both infant mortality and overall life expectancy. Reducing prenatal wait times in Canada would also seem to improve their infant mortality rate. Slide 13. Chronic diseases in adults also appear to be higher in the U.S. 68% of adults 65 or older have been diagnosed with at least 2 chronic conditions. Only 56% of the people in Canada fall into this category. These diseases in the U.S. could be attributed to individual behaviors such as diet and exercise. In addition to smoking that was previously discussed, one explanation could be that the U.S. has one of the highest totals for caloric intake, sugar intake, and fat intake among all OECD countries, while only eating an average amount of fruits and vegetables. This, coupled with low levels of physical activity, leads to high obesity rates. Recent estimates suggest that obesity could account for 2/3 of the U.S. shortfalls in male life expectancy and as much as 2/5 of the female life expectancy shortfall. Slide 14. Lack of access to healthcare services is another reason the U.S. has poor patient outcomes as compared to Canada's universal system. A 2014 CDC National Health Survey, 35 million people under the age of 65 were uninsured in the U.S. An additional 30 million were also underinsured. These individuals received coverage from various providers, including public clinics, public hospitals, or private institutions who render care as charity or shift costs to other payers. Most often, uninsured patients in the U.S. are cared for in emergency rooms, the most expensive form of primary care, after it is too late for the preventive medical treatments. These events affect both the cost of healthcare and the outcomes of the patients. Increasing access to primary care has a significant potential to lower overall healthcare costs in the U.S. Providing early preventative care will keep diseases from progressing into harder to treat forms. This could be delivered in the form of universal health coverage, like Canada. In the U.S., people see a doctor 4 times a year, on average, compared to an average of 6.5 times per year for the 34 OECD countries. In contrast, Canadians visited a doctor 7.7 times a year, partially explaining the higher value of care provided when compared to the U.S. Slide 15. Many other things could be done to provide better quality care at a lower cost in the U.S. Pharmaceuticals appear to cost healthcare consumers more money in the U.S. than in other comparable countries. Americans were top consumers of prescription drugs in 2013, using on average 2.2 drugs per adult. Other countries like Switzerland and the UK use 1.3 drugs per adult. Prices were also higher on average in the U.S. compared to Canada, who had drug prices 50% lower than in the U.S. Lowering pharmaceutical usage and costs has significant potential to lower overall healthcare spending in the U.S. Slide 16. Developing a transparent method to understand what healthcare costs will also help reduce costs. As health insurance premiums rise, families will need to make more educated decisions when purchasing healthcare. For example, the U.S. Government Accountability Office recently asked a dozen healthcare providers for their price of a knee replacement. Estimates ranged from $33,000 to $101,000. This range in cost is much different than Canada's fee schedule negotiated with its doctors. If healthcare consumers in the U.S. could compare these estimated costs, they could be able to make better informed decisions. In addition to the consumer education benefits, price transparency could help lower the cost of healthcare. A study by the Robert Wood Johnson Foundation concluded that health economists and other experts are convinced that significant cost containment cannot occur without widespread and sustained transparency in provider prices. Slide 17. Many steps need to be taken to close the gap between healthcare cost and quality in the U.S. We need to have a deeper discussion of the importance of and role the U.S. healthcare system plays in our lives, especially as it relates to the poor and disadvantaged. Canada's model of universal care seems to provide better outcomes at lower costs for the country as a whole. However, providing services for no out-of-pocket costs has its drawbacks too. Canada's model shows that demand will go up and so will cost, which forces the government to raise prices or cut services. The net results for Canadians is less availability for treatment and long wait times for care. It seems neither system is as good as it could be.